to the Oration. It gives me great pleasure to introduce our orator, Sandy Middleton. She's a professor of nursing and director of the Nursing Research Institute at St Vincent's Health Network, Sydney, St Vincent's Hospital, Melbourne, and Australian Catholic University. And that's all I'm reading from her bio, because you can read all the rest. We asked Sandy to be the orator about 3 years ago, and events have happened, so you almost could have had an elephant in that time. And at the time, she did send me a draft of the oration and said, do you want to read it? And I said, no, I'd like to be surprised when you actually stand up and speak. And I probably could have read it because I wouldn't remember it now, and I don't know if it's changed or not changed, and she's not going to tell me. Now, Sandy, I do remember Professor John Daly talking about meeting Sandy when she was a ward sister at Sydney Hospital. And you went onto her ward with fear and trepidation because everything was in order, systematic, classic, alpha, all sorted. And I can attest to that characteristic hasn't changed, because last week we found ourselves on a flight back from the UK together. And before I'd even got my bag up onto the rack, she had her area all sorted. She'd gone into her pajamas, she was all ready. Everything in her little cubicle area was all sorted and well managed. And down she sat, and that was the last we saw of her, until just before we landed. And she was out doing exactly the reverse. Nice, tidy little bay, all sorted. So nothing's changed, Sandy. Thanks. Well, I could tell you the rest, but I won't. I'll leave the rest for her to explain to you. So without any further ado, it gives me great pleasure to introduce Sandy, who I've known obviously for a long time. And it's over to you. Well done.
Thank you very much, Christine, I think. I would like to acknowledge the traditional owners of the land, the Larrakia people, and pay my respects to elders past, present, and emerging. The title of my talk today is Leadership, Change, and the Age of Aquarius. It's an absolute honour and a privilege to be given this oration today, and I'd like to thank the Australian College of Nursing for this opportunity. I do remember when I was a junior nurse and I would attend the annual College of Nursing oration in the Great Hall at the University of Sydney. And one year I turned to my dear friend and colleague, the late Professor Judy Lumbey, and I said, I hope I am never asked to give this oration, as the honour and the esteem awarded to this privilege was daunting. So when Carly phoned me 3 years ago and said, will you give the oration for the 2020 year of the nurse and the midwife? Those words came back to haunt me, but it is such a privilege. Thank you so much. So the theme of this year's National Nursing Forum is Nursing Leadership Unmasked. My oration today is going to discuss nursing leadership, particularly in relation to nursing research. In particular, the role and responsibility every one of us has, no matter how junior, to collectively lead radical and overdue reforms in this area. I was reminded of this recently while watching a documentary series titled 1971, the year that music changed everything. 1971, remember that date. And you will note the subsequent musical references in my oration today. It was a year in which the youth of America decided that they really did not want to go and fight and possibly die in a war in Vietnam. A year in which Black Americans found a voice and a strong sense of their being within the civil rights movement. A year in which the women's liberation movement started, led in part by our own Germaine Greer, with the publication of her seminal book, The Female Eunuch. A year that saw a dramatic change in music that underpinned and reflected all this social upheaval, inevitably driven forward by ordinary people like us, who led by example and wanted to make a difference. From 1971, I want to now take you forward half a century to the present day, where change is again something we're all going through, and nursing leadership has been front and centre of the COVID pandemic. They say that it's only in war and pandemics that bring about real change, and it's clear that as a consequence of the COVID pandemic, change is happening at all levels of society, including the way we practice nursing and in the way we care for patients. How often over the last few years have you heard the phrase on the TV, the scientific evidence tells us? And isn't it an interesting sign of the times that the general public now know what PPE stands for and what epidemiologists actually do, as these words have crept into our daily language. In keeping with this theme of evidence to practice, my oration today will reflect on how this appetite for change and harnessing leadership relates to an opportunity for a commitment for improved nurse researcher training and a formalised clinician researcher career pathway, and why it is imperative for us now to move nursing research on with a sense of urgency. But first, to put all my comments into context, I'm going to tell you a little bit about myself. I am what's called an implementation science nurse researcher. So what exactly is implementation science research? It's the study of how we get evidence into practice. We know that just telling clinicians about the latest evidence will not change their practice, so we need to use proven, targeted strategies to help nurses integrate evidence into their everyday nursing care. Specifically, I have led a 15-year program of implementing evidence into stroke care. So back to 1971, patients with stroke were admitted to hospitals and often put out on the veranda or in the back rooms of the ward, which is where long-term patients were nursed, out of sight and away from the hurly-burly of the main ward. This is also because at this time there were no proven acute therapies for stroke, and we simply waited for their stroke disability to evolve before we could assess their rehabilitation needs. Now, some 50 years later, the patient with stroke is in a specialised stroke unit with care often led by a stroke nurse specialist, and we have time-critical therapies that, thanks to research, we know will reduce disability and improve quality of life. Reflecting on my program of stroke research, I have been fortunate to work with some inspiring nurse leaders over the years. In 2011, with a group of collaborators, I led a nursing research trial which nurses were supported to implement 3 evidence-based protocols to manage fever, raised blood glucose levels, and swallowing difficulties, known as the fever sugar swallow protocols. For patients with stroke, this initiated resulted in significantly less people being disabled and dying. But this simple change in nursing practice wasn't seen at the time by the stroke nurses as new or novel. We're already doing this, was their refrain, but our baseline research data clearly showed otherwise. So this research resulted in significantly less people being disabled or dying, and healthcare and societal costs of 317 million Australian dollars over 5 years. The paper was published in The Lancet within 5 weeks of submission. And as a result of this new scientific evidence, to quote from Carole King's 1971 Tapestry album, "I felt the earth move under my feet." This was a career high, and at the time I also foolishly thought, great, now all patients with stroke will receive this care because the evidence is out there and everyone is just going to start using them. Sadly, translation of evidence to practice doesn't work this way. We know it can take 17 years to get research into practice. And I also learnt that no one cares as much about your research as you do. So the holy grail for researchers is getting your research translated into policy and practice. And this is what we call impact. That initial publication may be a rush of joy, but it's only the first, albeit very important, step in research dissemination. Meetings, conferences, and a lot of "I heard it through the grapevine" type communication needs to follow to achieve true impact. Following on from our publication, a partnership with the New South Wales Agency for Clinical Innovation eventuated, which enabled successful implementation of these stroke protocols into all 36 hospitals in New South Wales. The grapevine of research communication then spread to Europe. A chance email arrived in my inbox from a not-for-profit organisation that were working in Europe to improve stroke care, asking whether I would work with them to lead a program of implementation research to roll out the fever sugar swallow protocols across Europe. We formed a unique collaboration with the European Stroke Organisation and have just finished a study where we helped nurses implement the fever sugar swallow protocols into 64 hospitals across 17 European countries. Many of the participating hospitals were from resource-poor countries, for example, Armenia, Belarus, Kazakhstan, Slovenia, Uzbekistan. And some of these countries are on Marco Polo's Silk Road of Central Asia. But clinicians in many of these low and middle income countries had no access to the latest clot busting therapy nor clot removing surgery, so nursing care was likely to make a big difference to these patient outcomes. As a result of our research, we were again successful in assisting nurses to change their practice, with significantly more patients with stroke receiving evidence-based nursing care. The effects were large and consistent across all countries. And importantly, this wasn't about giving patients a drug or a device, but was achieved through evidence-based nursing care. That more patients received care according to these nurse-initiated protocols meant that more patients could go home to their families rather than to a residential aged care facility with significant disability. For me, this European study has been a career highlight, working with and mentoring the European nurses who are now becoming leaders in changing stroke practice. And the context here is important. Many of the nurses in these countries do not have nearly the same degree of autonomy of practice that we have in Australia. For example, the doctors will tell them how often to take people's temperature, and prior to this study, many of the nurses did not do swallow screening in their patients with stroke. My colleague, Professor Elizabeth McInnes, led a detailed process evaluation and received comments from the European nurses such as, "This study has changed my life." Many of the nurses stated they had never before participated in any kind of research or even a quality improvement study. Indeed, in one country, the stroke nurse then became the principal lead for the study and for the first time in her career was giving educational sessions to nurses and doctors and was presenting to them at meetings within her country. Again, ordinary people empowered to lead to do extraordinary things. And we were able to similarly assist other nurses to take on this expanded leadership role in Spain, Portugal, Poland, and Italy. Finally, quite by chance, we found a video posted on Twitter from Kyrgyzstan, another Silk Road country, and not even officially in our study, that showed nurses walking around outside holding copies of the fever sugar swallow protocols that had been translated into Russian and conversing with each other. At the time, we had no idea how the protocols had made it that far into Central Asia. And the nurses from these countries all became true leaders, and I feel humbled to have been working with them. So this brings us back to what exactly is the impact of nursing leadership in delivering change in clinical practice. Change champions are, by definition, disruptors. This word has now crept into our lexicon, and where it once would have had a negative connotation, it's now synonymous with innovation. Disruptors challenge the status quo, they look for gaps and opportunities to do things differently, moving on from historical methods. Other 21st century disruptors have been phenomenally successful. For example, one of the biggest taxi companies, Uber, owns no taxis. One of the world's biggest accommodation companies, Airbnb, own no beds. And in nursing, one of our successful models of care, Hospital in the Home, owns no inpatient beds. Another challenge for our profession is that we need to be patient-focused, not profession-focused. We must break down the clinical silos so that patients should not have to conform to the system, but so that the system conforms to the patient. New models of care should be about what yields the best outcomes for patients, and perhaps focusing on the real world of complex multimorbidity. There are many excuses given for not changing nursing practice, and the most dangerous of which is because we've always done it this way. Think about those 8 little words can so easily condemn us to professional mediocrity, if not irrelevance. Further, too often, when attempting to introduce new systems and ways of working, we hear, "Oh, well, that's not part of my job." Well, I would argue that anything that improves patient outcomes is part of every nurse's job. I recently listened to a podcast by one of my collaborators, one of the world-leading implementation scientists, Professor Jeremy Grimshaw, who said, if we can implement evidence with even small effects, this will have a large population effect. And nurses work in teams, so it's about collective practice and leadership. To achieve a population effect, we need to be sure the patient is getting evidence-based care from every nurse on every shift. So in nursing, we now need not just to talk the talk, but we also need to walk the talk. We must nurture our potential disruptors and leaders, even if they don't yet have a job title to match their big ideas, and give them the opportunity to implement innovative ideas. Even our junior nurses have a contribution to make here, and it shouldn't be about age, but more about leadership ability. But how do we identify and enable these qualities in ourselves and others? I was recently in a meeting with a young industry leader who reiterated Facebook's Mark Zuckerberg's philosophy on move fast and break things. This amused me, but it got me thinking. Are we in nursing assured in our leadership skills that we are prepared to enable each other to move fast and break things? This is completely contrary to how we've worked in the past and often encumbered by our historical mindset of that's not the way we do things around here. But indeed, COVID has shown us how well-placed nurses are to lead rapid health system change. But importantly, things do break. In other words, we need to accept that not all innovations will succeed and some will fail. We have to learn to accept and embrace failure from time to time. It is the price of progress. If you work at the cutting edge, you have to be prepared to bleed. You may be wondering about the title of my talk, Leadership Change in the Age of Aquarius. Well, in the early 1970s, they sang about the dawning of the Age of Aquarius. Well, what you may not be aware of is that this astrological event is thought to be commencing about now. Apparently, this happens about every 2,000 years when the sun aligns with the zodiac constellation of Aquarius. So we are now in an age of innovation, of disruption to the established order, of empowerment, of leadership, and it's clearly auspicious for nurses. So can this disruption be evidence-based? How do we enable nurses to break things in a way that facilitates positive change and paradigm shifts? Systematic implementation of evidence is imperative, but where that evidence is missing or hopelessly out of date, then research must step in. We know that within the healthcare system, the stronger the research environment, the better the quality of care and the improved patient outcomes. So we need to set up and test new initiatives, but we must do so with rigorous research frameworks and evaluate their impact on patients and the healthcare system. I am now working with the directors of nursing at 8 hospitals across New South Wales and Victoria in a multi-site trial, the Accelerate Plus trial, to improve systematic patient assessment and bedside communication involving nurses and patients in 24 wards in these hospitals with the aim of reducing patient deterioration, falls and pressure injuries. These are key issues so problematic in nursing at the moment and indeed have been and always will be. And you may well ask, so what's the big disruption here? In 1971, the late Marvin Gaye saw inequality and saying, what's going on? Well, in this trial, we're getting nurses to ask the same questions about their patients. Do I really know and understand what is happening to this patient under my care? Have I effectively communicated this to my colleagues and to medical staff? We believe that improved systematic patient assessment at the start of every shift, rather than just vital sign monitoring, coupled with improved communication at the bedside involving the patient and nurses' active participation in ward rounds with the multidisciplinary team, will reduce patient deterioration. What will make this a success is the outstanding collegiality and collaboration between the nurses and the nurse researchers, and particularly leadership from the directors of nursing. Their willingness to support this model and the rigorous evaluation of this initiative is crucial to its wider impact just beyond our participating hospitals. So while progress in nursing research has advanced since I began my career, it's been incremental and slow. A key challenge for the future of nursing is the lack of nurse researchers. Currently, less than 1% of nurses classify themselves as active researchers. This is not good enough. A further challenge for the future of nursing is the lack of nurse researchers with experience leading randomised controlled clinical trials. And I can see how this has come about. And in the late 1970s and 80s, nurses were only able to gain their PhD through social science and arts programs, as PhD programs in nursing were not available. As such, nursing developed expertise in qualitative research methods, which indeed have delivered important evidence to inform nursing care. However, mentors and training in quantitative research methods, including clinical trials, were sadly lacking. This was further compounded by an active nursing culture of disdain for all things quantitative in the field of research within nursing. I remember my proposed master's research, which used quantitative research methods, being denigrated by a senior nurse academic who disparagingly described it as reductionist and conforming to the medical model. It quickly became evident to me that this was the worst sort of betrayal by a nurse researcher, but it was a commonly expressed opinion at the time. But yet I persisted. Unable to find a nurse with experience in quantitative research methods and who could supervise my PhD, I subsequently undertook my PhD via the University of Sydney Faculty of Medicine, where I obtained excellent research training in clinical trials that I believe has underpinned my successful grant applications and research career. So with all of this in mind, what is my recommendation for better and more effective nursing care? Clinically relevant, randomised controlled trials, run by well-trained nurse trialists, supported by qualitative research to understand how and why interventions work. In other words, a balanced academic mix from both quantitative and qualitative research methods with a strong clinical underpinning. Another issue hampering the growth of research in nursing has been the lack of research funding, a compounding factor for many years. I remember a senior colleague actively discouraging me from putting in a grant application to Australia's premier health research funding body, the National Health and Medical Research Council, or NHMRC. "Oh, Sandy," she said, "nurses don't get NHMRC grants." Fortunately, I didn't listen. I submitted my grant to the NHMRC and it was funded. A recent editorial by Dr. Caleb Ferguson noted that in the 2020 NHMRC Research Training Scheme round, only 7 nurses, which is 3% of successful applicants, were awarded investigator grants. In the same 2020 NHMRC Postgraduate Scholarship Scheme for PhD students, only just one of the 64 was awarded to nursing, to Natalie Gavind. Similarly, in 2021, only one of the 65 went to a nurse, Desiree Legrap. Congratulations, Natalie and Desiree, on this outstanding achievement. This is less than 2% of these postgraduate scholarships going to nurses. Thank you. Clearly, this is unacceptable when nurses comprise the majority of the healthcare workforce. Undoubtedly, as has already happened, many emerging nurse researchers will nevertheless rise to the top unaided. However, we have a lot more to actively do to support them and others on their career path. We can't let research training happen in an ad hoc manner. We need to foster our nurse clinician researchers so they can be competitive in research funding schemes. And unfortunately, it's not the routine culture of nursing for nurses to be released from bedside nursing in order to undertake research. And unless we do this, we will be underserving not just nurses, but also our patients. Currently, we expect clinical nurse consultants to undertake research as part of their role, but this is manifestly unfair, as not only do we not give them adequate time to do research, but we have systematically underprepared them for this important part of their job description. We need more targeted nursing PhD scholarships and in particular more joint clinical and academic nursing appointments at both postdoctoral and professorial level. This requires joint investment from both universities and health services. This is a priority, otherwise others will be back here with these same words in 10 years' time, but perhaps referencing music from the early 2000s. So you might ask, well, what am I doing to address this gap? Over the last few years, I have been working with my clinical and academic colleagues, and we have established the Nursing and Midwifery Implementation Science Academy as part of the Maradulu Budyaru Gumul Sydney Partnership for Health, Education, Research and Enterprise, or SPHERE, which brings together nurse researchers and senior nursing executives and clinicians from 4 local health services and 3 universities. Together, we have developed a clinician researcher career pathway for nurses to address this major gap in nurse research education and training, a pathway that we hope may have greater relevance nationally and beyond just the SPHERE organisations. And I have been working with nurse researchers from Australia and New Zealand to establish the Australasian Nursing and Midwifery Clinical Trials Network, led by Professor Marion Eckert, which we hope will support and increase nurse-led and midwifery-led trial and nurse midwifery trialists. So the time has arrived for our nursing leaders to take the profession forward. Research makes a big difference to our clinical practice and in turn to patient outcomes, and it's part of every nurse's business. But I know it ain't easy. And as the Rolling Stones song goes, you can't always get what you want, but if you try sometime, you find you get what you need. One of the most important lessons I've learned along the way is to never give up. If the front door seems closed, go around to the back door. And if the back door's closed, go in the window. Onwards, be persistent and build resilience. Change was happening in 1971 when David Bowie exploded onto the scene with Ziggy Stardust. Tomorrow belongs to those who can hear it coming, he said. Well, that day has now arrived, but we need to go further and faster. We need better collaboration with our profession to lead multidisciplinary, collaborative, multi-site nursing research that is clinically relevant to improve patient outcomes. This research needs to incorporate funded PhD students, funded nurse clinician researchers, and funded postdoctoral nurse researchers. We will need supported clinical academic research training pathways for nurses to achieve this goal. However, as Barack Obama said, change will not come if we wait for other person or some other time. We are the ones that we have been waiting for. We are the change that we seek. And all of this will require nurse leaders, which has to be every one of us here today. So in the words of Carole King, where you lead, I will follow. Thank you.